hearing. So if you can say names before you start, that would be helpful.
Sure. So actually, I'm sure Dr. Kang would have some great insights on this as well. So there's a great opportunity for AI in healthcare to serve as a, in certain screening types of applications. Whether we can actually go as far as saying we can build diagnostics is not entirely clear, right? Because I think to declare something as a test as a diagnostic, you would need to meet very high standards of specificity and sensitivity of the test. And you want to be extremely careful about declaring false positives. I think we were discussing with Dr. Manjunath about this earlier. So it's very attractive. I think the other attraction, so from a screening point of view, certainly I think we should be looking forward to, for example, oral cancer screening, just from imaging. I think Dr. Vishal Rao and I work on the oral cancer task force for the country. And there we are starting to see that you could get some early indications, and then you have to have a further investigation after the AI into actual molecular pathways, and you should also have a clinical pathway well defined, so that if there is the possibility of a false positive, you don't put the patient under, or the potential patient under, all kinds of mental stress, because they now have been told that they have a risk, and you need to be able to resolve how they get tested. So there are positives. Another big positive is, of course, our Ayushman Bharat digital mission. We are going to be collecting data. We're going to be creating large digital lockers. And so the ability to leverage that is important. On the negative side, I would say there is a big challenge with certain types of AI. And we were discussing this at lunch, generative AI, because of the hallucination problem. And, if you start using generative AI, you start maybe hallucinating and creating more data, which then eventually takes over, even the little high quality data we have. And therefore, you just have to be very, very careful about certain AI technologies like generative AI, and most of the excitement is about generative AI. The other challenge is, please remember that these are black box technologies. When you run a neural network, a deep neural network, there is something that comes out. How do you actually know what it is saying, and how do you explain the conclusions it's arriving at? And unless you can tie this into understanding of some mechanisms, biological pathways and mechanisms, this is not going to meet any regulatory standard, right? So I think there are challenges, so pros and cons, I think they have to be balanced.
Dr. Vishal Rao, the question I have to ask you is, in oncology, the use of robotics, and in combination with artificial intelligence as well. Tell us, how is it changing the way cancer treatments are done in this country, and more importantly, what can we look forward to from here on?
I'll answer this in two parts. Today, if you look at AI as a broader sense of it, there are 4 stages of AI. The narrow general intelligence stage, then you have the limited memory AI, then you have the theory of mind, and then you have the self-aware AI. These are the 4 phases. Now, what we are doing with robots right now, and I can give you an experience of just a couple of months back. We were at Sunnyvale in California at the world's largest robotic summit surgery meeting, and representing India was a very proud feeling there. and talking about actually looking at what is happening. There was a driverless car, there was a robot that came into our hotel room to take our order, and we were looking at how machines were interfacing with humans in reality. So we are at now a stage of limited memory AI with driverless cars. I mean, Elon Musk has touched it. What Stephen Hawking was worried about was when we reach self-aware AI. That means when we are going to reach an AI with intelligence, emotive intelligence, or when we are going to reach an autonomous conscious AI which is going to be independent, is when Stephen Hawking said that the society needs to get worried about. Let me tell you, this is 2019 October, and I'm giving some talk, and I'm telling 10 years from now, we will be looking at theory of mind being cracked, and we all have to accept it that we are moving fast. June, July 22, I got an email which read, Blake Lemoine has been sent on gardening leave by Google because he's cracked theory of mind. That is June 2022. And this is 2 years of COVID. Now just think of this. If we have touched theory of mind now, 1 year or 2 years back, correct? We are talking about a rapid acceleration of artificial intelligence, which is much beyond the control of our comprehension. And that's what I'm talking about. Gen X, then we have millennials, we have Gen Z, now we have Gen Alpha.
Yeah.
So it's accelerating. I'm a robotic surgeon, and I'm learning to play Xbox video games because you need to be very good at that. Correct? You need to be. So I'm sitting with my kid there playing some Xbox, playing PlayStation, and I'm asking him, can you help me with those hand controls, because I need to be doing this surgery also. We do one of the largest surgeries in the south in head and neck, in robotics, and we've invented our own instruments, we've invented our own processes, data. And for me, it's been a great learning that robotics is here to accelerate, accentuate, and assist human healing. It's not here to replace humans right now.
Okay. Dr. Kuldeep Rai Zada, if I were to ask you the same question, this is something I'm going to ask. The moment you say robotics and robotic surgeries, people think it's like a video game. So the doctor doesn't do anything, the robots do everything. Is that how it works?
Not really. Things are very different from the perception versus reality. When we are talking about, as doctor is talking about, like learning his own ability to operate even the robots, it's actually the learning curve that one has to go through. It is not that you buy the DVC machine and operating from tomorrow, it's not going to happen. Every surgeon, every physician, or every clinician actually need to go for the learning phase, and then they are going to get an excellent performance on that part. So just buying the DVC or any kind of high-end robotic system is not going to help you with that bit. My experience is coming from ophthalmic community. I am from ophthalmic background, and I work with the industry large scale. We are from medical device industry here. We have close to 110 in medical industry, and my experiences goes very widely because I work with every single domain of industry. Talking about let it be nephrology, let it be cardiology, let it be ophthalmology, let it be dental or anything. And I have seen a lot of changes actually happening. And when I talk about the AI application, it's not coming only AI, it's coming with the deep learning and machine learning as well. And whatever actually is happening in particular aspect right now, the amount of the AI that is being used in medical science is very small and very little. But for the current world proposition that now another 10 to 15 years or 20 years down the line, this is going to play a very crucial role. Because most of the technology what is existing today, that will be vanished. It won't be existing another 20 years down the line. And you will see, me and you will be aging together, and we will see the witness what's happening today. Now, for example, we talk about the cataract, we talk about the glaucoma, even surgery or production is all going to be variable. Now, if you look at last 20 years before, you can't actually just diagnose a glaucoma just looking on the parameter or fields and see. But now you have advanced advantage when you actually have the photography of the retina or fundus. You are able to have analyzed, and you can tell this patient is potentially going to have a 5 year down the line the glaucoma, and potentially will lose in 50 to 20 years of the eyesight for this patient. Thank you.
If I were to ask you something, today, these days we say with the amount of screen time that we have, our eyes are going, in the wrong direction. The eyes are failing its powers faster than what it used to be. Are you telling me that technology is catching up faster than the way our eyes are worsening?
Yeah, it is true. It is already documented in many of the journals around the world. It is actually inducing a lot of myopia, especially for the children who are between 3 to 8 years of the age. And that's one of the area, cautious, especially that will become very high prevalent in the time of the pandemic, because all the school, everything is gone to the iPads and tablets, and all the parents have no choice just to give the gadget to them. And they become so addicted, not only it disturbs their sleeping pattern, along with that, the sight, the retina is elongated and they're developing a high correction. We do a large screening, and last year we did actually the work with the Telangana government and Andhra government, and we have done almost 11 million people screening and delivered the eyewear to them. Where we realize right now, earlier the potential for the eye problem was only 9%, now it is to 37% in the children, which is causing a lot. Is evidence, is all available everywhere.
Okay. Okay. At this stage, let me invite upon stage Dr. Arvinder Singh Soin, who has just joined us. Ladies and gentlemen, huge round of applause for Dr. Arvinder Singh Soin. I'm just coming to in just a bit. We have Dr. Syed Ghaus in the house. I have to ask you one simple question. In nephrology and neurology, tell us, how do robotics and artificial intelligence play a role? And more importantly, how do they improve precision and accuracy?
Yeah, in urology, to be more particular, urology is one branch where robotics is used most extensively.
More than physiotherapy?
More than anything in any other branch, urology is one specialty wherein robotics is used to a fullest extent. To take an example, you have got a deep organ which is known as prostate in males, and there is an increasing incidence of developing malignancy which is known as prostate cancer. And to treat that when it is surgically treatable, robotic is the best possible way where you can access it in such deep pelvis with lot of precision, preserving the neurovascular bundles which are all around it, preserving the ejaculatory function of the patient, because the sphincter mechanism which holds the urine, the control of urine when the patient has an urge, that is there, and we tend to go there, scoop out the prostate from there, and then suture back the bladder back, to its own position. So this precision is possible only with robotics. We would have done it in an open technique or a laparoscopic technique, but the precision, the early recovery to continence, the precision with the entire tumor is removed, the damage to the neurovascular bundle and surrounding organs, all this would have gone multiple times if you have done an open surgery or a laparoscopic surgery. So with that, we have seen all the generations of open laparoscopic as well as robotic, and I myself can vouch for it that robotics has done leaps and bounds in terms of precision.
Okay. Dr. Arvinder Singh Soin, when it comes to treating liver diseases, performing liver transplant surgeries, and also diagnosis, tell us from your experience, how exactly do both artificial intelligence and robotics play a role?
So, I'm not sure if you've discussed this before, but artificial intelligence plays a increasingly bigger role in, first drug discovery, diagnosis, prognosis, treatment, because, so for example, in drug discovery, initially, basically it was a manual process and people looked at statistics of how the previously existing drugs were performing, what their mechanism of action was. But this is now all built into AI algorithms, right? So from a choice of 10,000 molecules, it's easy to zero in on 5 or 10 that are likely to work because the algorithm has the mechanistic evidence. That means how a particular drug works, how well they work, on what populations they work, with what symptoms and what diseases they work. So all this is into machine learning and AI algorithms now, and basically if you're asking a question, you will get a pat answer that these are the 10 molecules or 7 molecules you guys should research and should be interested in the order of, I mean there's a pecking order, which one is most likely to work. So drug discovery cost and time has been like exponentially shortened.
Okay.
It is much, much less than it used to be. I mean, this whole process of choosing the right drug would take anything from 3 to 5 years. It takes a few weeks. That's all, right? So that's just the drug discovery story. And then, of course, it also factors in genomic data, transcriptomic data, proteomic data, and then zeroes in on the right drug or the molecule to research. So that's one part. Diagnostics. Now, obviously, you treat diseases better if you can diagnose them better or earlier, right? So in diagnostics, specifically pathology and imaging, those are the two areas where AI algorithms are very good because they're good in image recognition, right? So image recognition comes in largely in pathology and imaging. So the diagnoses are picked up, I mean, the diseases are picked up much earlier, and early diagnosis is possible, and therefore treatment is more effective. And then finally, treatment. I mean, two people may have the same disease, but we have a different genetic makeup. So based on genomic and proteomic data, now AI algorithms can tell the doctors that this guy with hepatitis C is much more likely to respond to a drug, and this lady with the same hepatitis C, but of a different, she's of a different genomic makeup, obviously, is more likely to respond to drug B. So that's how AI has actually changed the way we look at drug discovery, diagnosis, and treatment. You asked me about
Yeah, because AI, we're discussing AI, but in terms of robotics, specifically speaking, talk to us in terms of how, robotics is playing a role today in a liver transplant operation.
So, the first of all, what the gentleman said here is absolutely true. Urology is the maximum highest user of robotics equipment and robotic surgery in the hospital. That's why I don't allow any urologist to come into my OR, because they just want to grab the robotic space and slot all the time. So we created a robot in the liver OT at Medanta. So we do majority of our surgery with robotic surgery. Now, robotic surgery, as you may have, others may have, my colleagues may have mentioned, that it is much more precise. There is a magnification, there is a 3D view. The surgeon sits at the console, operates in peace. Theoretically, he can answer text messages during operating, but we don't tend to do that. And so the tiredness story, the fatigue story is taken care of. The tremors are filtered, and the regular instruments which we use for open surgery, with our own wrist, have a certain limit to which they can reach. But the robotic instruments are wristed 270 degrees, and therefore they can actually get to nookies and corners where normal instruments and hands do not reach. So the precision and safety of surgery is enhanced.
Okay.
It is correct to say that 70% of liver surgeries, and including donor surgeries for transplantation, happen with robotics now. And people are, like, it's much easier to convince a family person to donate half their liver with robotic surgery, where they will have 3-4 small little holes and no big visible scar. They go home in 4 or 5 days, and they have an excellent recovery after robotic surgery. And the same story goes for all kinds of robotic
Absolutely,
surgery, right?
absolutely.
So it's definitely a game changer in liver surgery, liver transplantation.
Okay, let me take this across to Dr. Gagandeep Kang, who's been waiting patiently. By Dr. Gagandeep Kang, thank you so much for waiting patiently. I want to ask you about artificial intelligence in the context of clinical decision support in public health settings.
Thank you very much for the question. As you're probably aware, when we think about public health, one of the major issues that we encounter is the availability of people who are capable of making decisions in primary care. Now, this is a problem in India, particularly in rural areas. It's even more of a problem in places like Africa, where the number of staff that are produced that can provide healthcare at different levels of facilities is much less than in places like India. So recently, there have been a number of investments that have been made in looking at the tools that we can provide to people who work in primary care so that decisions can be made with access to all of the information that is possible in order to come to a decision. So these are clinical decision support systems. They actually started in hospitals at higher levels of healthcare, but are now being devolved into primary care as well. There are a number of such systems that have been deployed for vertical programs, such as in malaria, where they have been really game changers in making sure that patients are identified and are referred appropriately. The hope is that going forward, it will be possible for us to do much more of this. And interestingly, it seems like in these areas, perhaps because the need is much greater, there seems to be much wider both development and application and adoption happening in Africa than is happening in Asia. So I do hope that we catch up in India, but I do see this as being a potential game changer for the future of public health.
Dr. Vijay Chandru, I'm going to take off from what I asked Dr. Kang about, how do you make universal healthcare, affordable healthcare, possible? With now that we have artificial intelligence and the pace at which the technologies, health technologies in relation to artificial intelligence is growing.
Thank you. I think Dr. Kang just pointed out how clinical decision support systems are evolving to a point where it would be possible, even at a primary healthcare setting, to be able to advise, how the care pathway should be defined for a specific, community member who has come in for with a problem, right? I think we are going to see possibly an interesting development that for which I think our primary healthcare, community health workers, whom we call ASHA workers, for example, will have to be retrained to actually be able to do a lot more, both leverage some of these decision support systems, but also make measurements and the point of care testing, for example,